I'd like to move on now to the Check Your Knowledge section of the day. So this is going to be taken by James and Jenny. They're going to a double header on it, and I certainly, when I've listened to this in the past, although I'm aniridic, I think I know quite a bit about my condition. There's always been something that I've forgotten, or that's something that's been a good reminder, or even occasionally some new pieces of information. So I'm looking forward to this as well. So, James and Jenny.
Good morning, everybody. Okay, so yes, my name is James Buller. I'm one of the trustees, and this is my colleague Jenny Langley, who's also one of the trustees. This is a presentation that has been given at previous events under the title previously of Aniridia Back to Basics. But we've updated it in a number of areas with the sort of latest research and things, and we realised that there are a number of new people here who haven't been to a conference before. I haven't seen this presentation before, so we thought it was a good opportunity to bring people up to date, and people who hadn't seen this before would be a good thing for them. And even if you have seen it before, as Michael there was alluding to, in many ways it is a very complex condition and has lots of things associated with it, and so it's always good to check your knowledge and make sure that you're up to speed. Okay, so what are we going to go through? We're going to talk about what aniridia is, how you get it, what the kind of genetic causes behind it are, what the actual effects of not having an iris are. Then we're going to look at some of the associated conditions, and finally sort of start looking at some of the treatments. This is designed to educate you and kind of familiarise yourselves with all aspects of aniridia. So please, if you have any queries, if you kind of don't understand anything we're saying, please do pipe up and ask as we go through. On the other hand, if you have any more kind of in-depth questions, we recognise that we're not medical personnel, and we do have the question and answer session at the end of the day with our panel of experts. So perhaps leave any sort of more in-depth questions until the end. That would be great. Okay, it was called Checking on Knowledge. We're going to do just that. Throughout the presentation, we're going to flash over a few questions to see how well you know aniridia at the moment. So the first part of that is really quite easy, I hope. Just shout out as many different parts of the eye as you can. Anyone? Corneal, yeah. What else? Iris. Lens, great stuff. Keep going. Limbo cells. Oh, right, we're getting technical down. Yeah, good stuff. What else? Great stuff. Anything else? Have we had retina? Good stuff. Okay, so here's the diagram. I think you've got most of those. I'm not sure I heard fovea there, or macula maybe. I'll come on to that in a second. The chromoid, as part of the retina there. Yeah, lens. The ones that not mentioned there, which like a zonules, just hold the lens. I love that name, zonules. So, what does aniridia mean? Well, it's derived from Greek words, an, meaning without or absent, and iridia, which means iris. So put the two together and you've got without iris. But as Michael was saying, there are lots of other issues associated with it, which we'll come on to. So the iris is just a ring of muscle around the pupil, which is just a hole, basically, in the eye that lets the light in, and it's usually brown, green or blue in colour. Interesting fact, there isn't actually any pigment in the eye, it's actually just about the density of the iris and how the light is scattered throughout it that gives you the different colours. So there are different ways of describing aniridia, the extent to which you have it. So one way is by saying that it's only partial aniridia. That is that you maybe have a very thin iris, or there's just an arc of it there. Or total aniridia, i.e. there's no iris there at all, or at least none that you can see with the naked eye without a slit lamp, for example. Total aniridia is the most common, and it usually affects both eyes at the same time, and that's known as bilateral, i.e. it's on both sides, bi for two. It is possible that it only affects one though. So how do you get aniridia? Well, there are two sources. The main one that we're actually concerned with is congenital aniridia. So that's where you are born with the condition. But there is also traumatic aniridia, which, without going into too much gory detail, basically means someone has got a normal eye and then has some horrible accident which results in losing that iris. Now, because their eye was healthy to start with, that means they generally won't have all the other issues that we're going to talk about today, although of course whatever their accident has done to them may cause issues. So although we're very happy to help people with traumatic aniridia, that's not our main focus. So causes of congenital aniridia then. It's usually caused by damage to what's known as the PAX6 gene. Now, this is located on the 13th band of the short arm of the 11th chromosome. That makes sense, doesn't it? Think of it like in a dress. Okay? All of us have 23 chromosomes. Okay? This PAX6 gene is located on the 13th one. On each chromosome there are two arms. There's the long and the short one. This gene is located on the short arm, and that's known as the P, rather than the Q arm. And within each arm there are a series of bands, and this one is located on the 13th band, so it's just an address. And so therefore it's known as 11p13. Now there are 600 different ways that that gene can be damaged or mutated in some way. However, one of them affects 50% of cases. 50% of people that have the PAX6 gene. Okay? I'll remember that one, there's going to be a question on that later. Okay, so that's basically what causes aniridia. There are other niche causes, but pretty much that's it. So you can have sporadic aniridia, which is where this PAX6 deletion or mutation happens randomly at time of conception. This occurs in roughly 1 in 47,000 cases. There are lots of different figures out there. That's the one that we use for a study relatively recently in Scandinavia. And so in this case, there's no known cause of it, it just happens, and there's no history of it in the family. Aniridia does not skip generations. Alternatively, you can have familial aniridia, which is basically where you inherit it from a parent. A parent will pass it on to their child. So it's not a different condition, it's still caused by genetics, and usually, but not always, by the PAX6 gene. So in that case, there will be a family history of it, and it's not gender specific either. So there is atypical aniridia, where there is damage to the PAX6 gene, but there are different symptoms, and they might be very mild symptoms, for example. And in a very other minority of cases, there will not be damage to PAX6. There will be other genes nearby that are affected in some way. Or even, it's just not known why you have aniridia. They haven't worked it out yet. So the inheritance. If you're going to inherit aniridia from a parent, if your parent has it, you have a 50-50 chance of passing it on to any children. It's because those 23 chromosome pairs split in half to create sperm and ovum, and depending on which half you get, because the aniridia gene is only in one side, 23 pairs, the mutation is only in one half, so depending on which half you get, you will not have aniridia as a child when that sperm or ovum conceives. And the symptoms may vary between parent and child as well, so just because you have kind of a certain level of aniridia or a certain level of sight doesn't necessarily mean that's how any child of yours might be affected exactly. So genetic testing. Recently, the HEFA have authorised the use of pre-implantation genetic diagnosis. This basically means that if you are a person with aniridia and you want to conceive, you can ask your local health authority to let you have IVF, and as part of that screen your sperm or ovums for the aniridia gene. Now there's obviously lots of ethics right top in that, so we won't go into it now, but that is now available. It's been recently approved by the HEFA in the past few months. If you are born with aniridic symptoms, you should have genetic testing to determine the exact mutation that you have. Is it PAX6, and if so, within that, which of those 600 different possible mutations you actually have, because that will kind of affect the kind of screening and things that you should have. So, aniridic quiz here again. What does an iris actually do? Right. Anything else? Helps focus, absolutely. Anything else?
From sunshine and from light.
Protects, yes, excellent point. Function of the iris. So the iris changes shape to control the amount of light going into the eye. When there's not enough light around, it dilates, i.e. the eyes get smaller, the pupil gets bigger, and more light goes in. And conversely, when there's too much light around. It's also very important that it actually blocks UV light in particular. So when it's very bright, there's lots of UV light, so it stops that going into the back of the eye and onto the lens and causing issues. Without an iris, therefore, your eye just basically looks black. You have a very large pupil, and you're unable to control the amount of light that is going into the eye. And this is known as photophobia, sensitivity to light, especially by sunlight. And it can also mean that it takes time to adjust to light levels. So when you're going from outside to inside, or vice versa, it can take more time than would normally be the case to adjust to that. And yeah, as I mentioned, the iris is, when it's fully expanded, would normally be blocking UV light as well. That can cause cataracts and things which we'll come on to. The other thing it can do is, because if the iris is not developed properly, it can be actually blocking the drainage channels in the eye, which is what causes high pressure. So because the PAX6 gene affects the development of the entire eye, the rest of the eye can also be affected in various different ways. So Aniridia pretty much always causes some degree of visual impairment, and it may be mild, relatively mild, or may be quite severe. And there are lots of other conditions associated with it. Some of these include foveal or macular hyperplasia. So right at the back of the eye, we've got the optic nerve, and just above that we've got the fovea. And within that there's a small dot, there's macula, and within that there's a small dot called the fovea. The fovea is a little pit, and that's where the light that comes through the lens is focused, right at the back of the eye, and that's where you see all the detail, how you perceive detail. Now the trouble is, if you've got Aniridia, you've got this gene, that's not as deep a pit as it should be, and so therefore there's not as many cells in there as it should be, and therefore you can't see as much detail as you should be able to. And that's known as fovea or macular hyperplasia. Okay, Aniridia again, your turn. Can someone with Aniridia be long-sighted?
Yes.
Anyone here who is? Good stuff. Excellent, yes. Well done. So yes, you're kind of familiar with being kind of short-sighted when you're visually impaired, but yes, it is totally possible to be long-sighted as well, because long-sighted, short-sighted basically comes from deformities of the lens, rather than the focal hyperplasia, which is doing the detail bit there. So yeah, so some people with Aniridia will have an issue with their lens, and just like anyone else who has an issue with their lens, it may be correctable with spectacles. But if you don't have a problem with your lens and it's just foveal hyperplasia, their glasses aren't going to do you any good, because you physically can't receive the information. It's being focused in the right place, you just can't see it. You can also have ptosis, which is known as a droopy eyelid, and this can kind of give the appearance of being tired and sleepy. At least that's my excuse. And that can affect kind of one eyelid or both. You can also have strabismus or squint, crossed eyes, look, often treated at birth, and I always try and say this, amblyopia, lazy eye. Let's talk briefly about visual acuity. So visual acuity is one way of measuring how well you can see, and it's typically measured in the opticians or eye clinic with what's known as the spelling chart, that letter chart that they point you at. And the levels of it represent different levels of sight, levels of acuity. So the top level represents 660 level of vision, all the way down to the penultimate line, which is what you should be able to see from 6 metres away if you had normal sight. That's known as 6.6, or in America, feet 2020. If you can see the bottom line, then you've got better than normal sight. And just above normal sight is the level that is roughly required for driving. If you are unable to see that letter chart, the alternative ways in order of checking what you can see, first of all they'll start bringing the chart just closer to you, 3 metres, 2 metres, if you can see the largest letter there. If that doesn't work, they'll sort of start showing fingers really up close. Can you see that? If not, can you see the movement of a hand, movement detection? And if not that, it goes down to light perception. Can you tell whether the lights are on or off or not? For children who are unable to recognise letters and kind of communicate in that way, they may use pictures. Can you identify this as a bird or whatever? Okay, I'm going to hand over to Jenny now.
So I'm going to go start talking about the associated eye conditions. So who can name the most commonly associated eye condition with aniridia? Nystagmus, yeah. So I'm going to talk about nystagmus first. So nystagmus is a constant rapid movement of the eyes. You might have heard of people with nystagmus being referred to as having wobbly eyes. There are four main types of the movement. You can have horizontal, vertical nystagmus, or you can have oblique nystagmus, which is a diagonal movement of the eyes, or rotary, which is a circular movement of the eyes. Nystagmus affects focusing, so if you have nystagmus, you'll have difficulty focusing, especially fast-moving objects, and also balance and depth perception, which is the level of surfaces. So if there's a step coming up or not, you might not be able to see it. People with nystagmus don't usually notice the movement of their eyes, but they will maybe be aware of where their null point is. And the null point is a particular position that's unique to everybody with nystagmus, that during each circuit of the eye, there's a particular position where the eye pauses for a few seconds, and that's called the null point. And when the eye is in its null point, that gives the individual a brief chance to focus better, and your null point is the direction at which you can see best. So you or your child, you might have seen tilting their heads upside down to watch TV, or practically hanging upside down and standing on their head to watch TV. This is to accommodate their null point and try and get the best out of their vision. Also, if you move objects closer to your eyes, the movement will decrease. So you might see people holding their iPads or phones or photos closer to their eyes, and this helps them focus better. And opposite is true. So if you move the object further away, the movement is likely to increase and make it more difficult for you to see. So my next question is, what kind of situation might make nystagmus worse? So the movement faster.
Tiredness.
Yeah, tiredness. There's quite a few, so keep shouting them out.
Flickering flame, like if there's lots of candles in the room.
Yeah, different light situations, yeah.
Stress.
Yeah, stressed, yeah. Anxious, nervous, ill. I think we're covering most of them, but yeah.
When you're drunk.
Yeah. Well, when you're drunk, your nystagmus actually slows down. Actually. I found when I had some vision that if I drank alcohol, then I would be able to focus better because it slowed my nystagmus down.
Now you know.
Yeah. So that's basically nystagmus. Oh, and I should say nystagmus affects both eyes usually, which is known as bilateral. So going on to cataracts. So can anybody tell me what part of the eye is affected by a cataract? The lens, yeah, that's right. So the cataract is a clouding of the lens. This can be present at birth, or it can develop at any time during the life. It's quite a common condition with aniridia. A cataract can be any size. It can be start off small and it can grow at any time. A cataract could make your vision blurry and distorted, and it could give you more sensitivity to light, or it could, in some cases, block the light coming into your eye, so you get less light. And with the cataract, a cataract can get worse, or there's an increased risk of a cataract getting worse if UV light enters the eye. So with aniridia, as was mentioned earlier, there's an increased risk of ultraviolet light getting in because your eyes are not protected by the iris. So it's really important for people with aniridia to wear sunglasses, so that lessens the chance of getting a cataract. So there's obviously no cure for cataracts particularly, but what can you do about them? You can remove the cataract by surgery, but with people with aniridia, less is more. You might have heard that phrase quite a lot, and this particularly relates to cataract surgery. So ophthalmologist surgeons don't tend to operate unless the cataract is very severe and actually affecting vision. And this is because the eye in a person with aniridia is underdeveloped and poorly formed, so there will be high chance of complications like increased chances of getting glaucoma or making glaucoma worse, or irritating the cornea and escalating the corneal disease. You can also, as well as having a cataract, you can have a subluxation, which is a distorted, dislocated lens. Cataracts can affect one eye or both eyes. So sometimes with cataract surgery, your lens is usually replaced by an artificial lens. But in some cases, it's quite complicated, quite risky to do this. So they will take the lens out, and that's called a lensectomy. When they take the lens out, they won't replace it with anything. And then this is known as aphakia. So if you're aphakic, you will have increased sensitivity to light because, you will just not have your lens, so you won't have that protection for the light. And also, you may be short-sighted, so you might need glasses to correct this. Okay, so going on to the next associated condition, so high pressures and glaucoma. So you probably have heard doctors talking about high pressures or eye pressure. Can anybody tell me what the normal range of eye pressure is? The lowest number to the highest number, so.
10 and 21.
Yeah, 10 and 21, basically that's generic really. So everybody has a small amount of fluid in their eyes to keep the structure of the eye, and this is between the lens and the cornea, or the iris and cornea. And so this fluid keeps the structure of the eye, as I said. And with people with aniridia, the drainage channels in the eyes may be poorly formed or poorly developed, or they might just stop working or not be as effective as a typical eye. And so the pressure in the eye, the fluid, can build up and become trapped and not have anywhere to escape. So that is known as high pressures. And when damage occurs to the optic nerve, this particular damage is called cupping. So when you have cupping as well as high pressures, that is known as glaucoma. So we'll go on to my next question. So what's the preferred treatment, the first preferred treatment of high pressures? Yeah, eye drops, yeah. So basically I should say that you normally get your pressures checked about once or twice a year, although it depends whether you do have glaucoma. Obviously, if you have glaucoma or high pressures, then you're monitored more regularly, but generally it's once or twice a year as the general guidelines. Adults are tested in an office with, they're given a local anaesthetic drop, and there are several different types of machines that can be used, and I won't go into those because there's quite a few, but and it's quite detailed. But basically, the general term for it is tonometer, which I always have difficulty with saying. But and with children, as mentioned earlier in the keynote speech, often children can have EUAs, examinations under anaesthetic, which means that they're given anaesthetic and their eyes are tested, their pressures are tested while they're asleep. And this is because crying can give a false high reading of the eye pressures, although as we heard earlier, this is becoming less difficult to test pressures in the office for children. So yeah, going back to the treatment option, the first treatment would be eye drops, and as we'll hear later about the cornea, it's best if you can have preservative-free versions of eye drops, and we'll be getting into more detail about why later. But so can anybody shout out any eye drops? Tomopta, yeah. Yeah. Alphagan, Zalatan, there's loads of them, and I've probably had all of them. So yeah, you can have one, or if that one doesn't work, then you can have 2 or 3 different types. And then if that becomes ineffective, stops working, you can sometimes, as a short-term measure, have oral medication. An example of this is called Diamox, and it's the most disgusting thing ever, I can tell you from personal experience. And this works in a very fast way to bring down the pressures, but it should only be used as a short-term method because of its side effects, basically. So if those treatments don't work, so eye drops or oral medication, the next is surgery, and they go for the less invasive method first, and that would be laser treatment, which is where some of the cells that produce the fluid in the eye, they're turned off basically, so they stop producing fluid, so there's less fluid being made by the eye. This has to, again, is a short-term treatment, and it has to be repeated more than once, and the more chances of it being repeated, the higher risk of complications. So doctors usually, it's quite controversial whether doctors use this method or not really. So the next step up would be making drainage channels out of their eyes. So you might have heard of trabeculectomies or trabeculectomies, and another hard word. And these are when, like I said, they make artificial channels for the eye for the fluid to drain out of. And then after that, the next step up is shunt or tube surgery, where you actually have some materials that are put in your eye, and you have a tiny tube and a plate that acts as a reservoir that flushes away the fluid in the eye. Hand over to James.
Thank you, Jenny. Okay, ARC. A-R-K. What does ARC stand for? ARC is Aniridia-related keratopathy. You may have heard of keratopathy just by itself. Keratopathy is basically cornea disease of some kind. And here we're talking about it particularly in relation to Aniridia. So the cornea is basically the clear part of the eye at the front of the eye that protects everything else behind it. And it is continually growing. There are what are called limbal stem cells. And these are basically continually repairing and renewing the cornea. And this means that they are basically stopping the rest of the eye, the kind of white of the eye, from encroaching on this clear window into the eye. And they are constantly doing this. Now the trouble is that if you have the PAX6 mutation in your genes, that these limbal stem cells don't work properly. And we'll hear from Victoria and Martin a bit later about why this might be the case, and research into it. So, as a result, the cornea is not being renewed as effectively, and so the white of the eye starts growing over it, and it starts becoming very cloudy. It's basically a breakdown of the barrier between the conjunctiva and the cornea, the surface of the eye. And so, yeah, things like blood vessels start invading, basically. It starts at the edge and works its way inwards, and it ends up just becoming cloudy, like looking through a condensated window. Then we've got the lens, the cornea protecting everything behind it. So what are the symptoms of ARC? Well, primarily what's known as dry eye. Your eyes might feel gritty or irritated in some way, and they might actually look red and inflamed. And you might have a kind of burning sensation, or conversely they might just be more watery than they should be. And as everything, you may have increased photophobia. The cornea can also be scratched, and if it is, then that can sort of further impair the ability of the stem cells to repair it. So that's the symptoms. How can we treat those symptoms? Well, one way of treating is with a bandage contact lens, while there's a scratch to sort of give that time to heal. We can be given preservative-free eye drops, which are basically artificial tears to make your eye more lubricated, and so reduce the amount of damage that's happening. So whether the eye is, your eyelids closing, and so on, you're constantly slapping off cells, basically. So these can kind of give more lubrication in there to reduce that happening. Now, it's important that the drops are preservative-free, or any drops that WAGR has, but preservative-free, because those preservatives themselves can damage the cornea. Now, normally that wouldn't be so much of an issue. The stem cells would just power up again and damage it, repair it some more. But now they're not going to do that. So it's important to get preservative-free eye drops. And there's an increased risk of keratopathy happening if there is any injury or incision to the eye, such as surgery. And also, if you were wearing a contact lens, then that would again constantly be rubbing up against the cornea and damaging it. And so, for that reason, contact lenses are not recommended for long-term use by Aniridia. So that's treating the symptoms. Can we actually do anything about the issue itself? Well, surgical options are considered when the vision is becoming severely affected. And one thing that can be done is known as scraping. Doesn't sound good, does it? Basically, you scrape off the scar tissue, the damaged part of the cornea, and hope that underneath it is some clearer stuff that can be seen through. So that's kind of viable if the limbal stem cell production is not too bad, and the cornea will be able to kind of repair itself a bit. You can also be given serum eye drops. These are eye drops that are made from your own blood. Some people here may have had that. And they may be used in conjunction. There's also an implant known as the Boston K-Pro, which is an artificial cornea. So you take the natural one out and put this artificial one in. And it's not very common here in the UK, it's a lot more common in the US, mainly because there are some issues with reading your pressures once you have a K-Pro implanted. Okay, what about any alternative ideas for treating this issue? Well, how about going and getting a new cornea from someone else, from a donor, or some donor stem cells? So, yes, you could have a cornea transplant, and again, some people here may have had one. However, the trouble is that those stem cells are not going to be able to renew that new cornea either, so that's just going to become cloudy within a few years. And it's a similar story with getting a limbal stem cell transplant as well. You can have an allograft, you get a donor, a living donor from somewhere, get some stem cells from them, grow them in the lab, and put those onto the surface of the eye, and it gives the eye a bit of a boost for a while, but it doesn't last terribly long, that's the trouble. And now researchers are starting to look at autografts, basically taking stem cells from elsewhere in your body, primarily the mouth, again growing them and putting them onto the eye. The advantage of that is that you won't have issues with them being rejected and having to take immunosuppressant drugs and things. So research on that is ongoing, and we'll probably hear about that later. While we're talking about kind of surgeries and things like that, it's worth talking about iris prosthetics. So there are ways of basically making your eyes look more natural, as it were, of giving an appearance that there is an iris there, and also sort of blocking the amount, having to block the amount of light that's coming into the eye. So to give them a more normal appearance. So there are a few different ways of doing this. Implants. It is possible that particularly when you get a cataract operation done and they're replacing the lens, they can add basically an iris prosthetic on the back of that and implant it alongside it. So this will give you a fixed iris. So it will be a fixed size, it won't change the size. So it will help when it's too bright, it will cut down the amount of light, but when it's too dark, you'll be getting less light in than you were originally. So it's kind of, you have to play the averages on that. As we said before, surgery is generally avoided whenever possible, so this is really only done alongside a cataract operation that needs to be done anyway. It's worth mentioning that there are a couple of other ideas, but not recommended. You can tattoo the cornea. Yes, it is possible to get a tattoo on your cornea of an iris. Again, the cornea in adults is not very good, so that would be a bad idea. Anyone with a smeller can get a contact lens that has got an iris painted on it, which can be useful if you want to change your appearance. As you mentioned though, the contact lenses are going to damage the cornea and so should not be used for long periods. Okay, your turn again. How many different aniridia causing mutations are there?
600.
Well done, start right. Yes, and one of those 600 affects what percentage of people?
50%.
Well done, good stuff. So, why do we mention this? There is a therapy known as START therapy that has been developed, and it's using a drug called atalurin. And it has been found that in a few mice in the lab that they were given eye drops containing atalurin and their eyes developed. They'd already been born, they got some eye drops and basically their eyes continued to develop miraculously. So there are some human trials that are underway in the US at the moment. But the key thing is that this treatment only works for about 50% of people with that one mutation in PAX6. So if you don't have that specific mutation, or you don't have a PAX6 mutation at all, this treatment would not work. As I say, it's still in trials. There is a leaflet in your packs from a researcher who is keen to start a trial in the UK. If you are interested in that, in particular if you already know your mutation, have a look at that and get in touch with her either directly or there is a sign-up sheet on the information desk at the back of the room. Put your name on that and we will pass your details on if you're interested.
Oh yeah, so recap, which chromosome is the PAX6 gene found on?
11.
Yeah, chromosome 11. And can you remember the band?
13.
13, yeah. Okay, so sometimes you can have the PAX6 gene deleted with Aniridia, or you can also have other genes in the same region, so the same band, or neighbouring bands deleted as well. And this is known as WAGR syndrome, or 11p deletion syndrome. And particularly, most cases you have the PAX6 gene, one copy of the PAX6 gene deleted, and you will have the WT1 gene deleted, but not always, but in most cases with WAGR syndrome or 11p deletion syndrome, the WT1 gene, which is neighbouring gene to PAX6 gene, will be deleted. And if you have a deletion of the WT1 gene, you have a 50-50 chance of having a Wilms tumour, which is a kidney cancer, a childhood kidney cancer. So that is why people with sporadic aniridia, it's very important that you get genetic testing to see if you've just got a mutation of the PAX6 gene or if there's more genes that are deleted or mutated than just the PAX6 gene, and if it affects the WT1 gene. If there is a mutation or deletion of the WT1 gene, then it's advised that you get ultrasounds every 3 months up until the age of 8. So what does WAGR syndrome consist? Well, basically, Wilms tumour, so the 4 letters, WAGR, stand for one of the 4 main conditions that you may have if you have WAGR. So W standing for the Wilms tumour, A for aniridia, obviously, G for something I can never say, genital abnormalities, and R is range of developmental delays, so a range of learning difficulties. And so you may have one or generally people with WAGR or 11p deletion syndrome will have 2 of these main conditions or more. And I myself have WAGR syndrome, and I believe there were a few other families here today that have WAGR syndrome, and the International WAGR Syndrome Association, who are based in America, they've kindly paid for us to have a room today. So if you're a WAGR family, we're having a meeting at 3 to 4 in that room this afternoon. Looking forward to chatting to you then.
Okay, a quick look at some of the other conditions that are related to aniridia. So the PAX6 gene is fundamental to development of the eye, and that's why it can affect all these things that we've spoken about so far. But it's also important in developing other parts of the body as the embryo grows. And so as a result of that, there can be a few other things that we can have issues with. So these effects are under varying levels of debate as to their veracity and scientific research and so on. So we have to be a little bit careful about what we talk about here. There has been some suggestion that there are links to some behavioural issues, some things around diabetes and pancreas problems. Joint pain has also been suggested, and an impaired sense of smell slightly as well. And two of the more well understood associated conditions are, first of all, a small pineal gland. The pineal gland is in the base of the brain, and it produces a hormone called melatonin. Now, melatonin basically makes you feel sleepy. It tells you when to go to bed. And some people with aniridia have found that if they basically don't feel sleepy at the right times. And they found that if they take melatonin supplements, like vitamin supplements, that this helps. So the kind of suggestion is that this small pineal gland is not producing enough melatonin in people with aniridia. Melatonin is a little bit tricky to get hold of in the UK. Despite being a totally natural hormone, you can't actually get a prescription for it very easily. You have to get off licence, and so you have to get consultants involved and things. It is much more widely available in the US. Another condition is called CAPD, Central Auditory Processing Disorder. Does central auditory processing disorder affect A, the ears, B, the eyes, or C, the brain? Who thinks A? Who thinks E, the central auditory processing disorder? Who thinks A? Say yes.
Yes.
Who think it's B, the eyes? Say B. Anyone? No. C, the brain. Who thinks it is?
Yes.
Okay, well, half of you are right. CAPD, Central Auditory Processing Disorder, it does actually affect the brain. You can hear perfectly well, there's nothing wrong with your hearing. It affects the ability of the brain to process sounds correctly. So this may kind of affect your ability to kind of filter out a conversation from background noise, for example, in a kind of busy room, or perhaps just kind of comprehend words sometimes. And it's basically about a kind of linkage between the kind of left and the right brain. And again, the PAX6 gene hasn't helped that link develop quite properly. There are diagnosis and aids available for that on the NHS, which we can give you details if you would like. A quick word about some similar iris abnormalities to aniridia. There's what's known as Gillespie syndrome. It's a very rare form of aniridia. It affects roughly 2% of people who have aniridia. And it's commonly also associated with cerebral ataxia and learning difficulties. And then there are things like a Peters anomaly, and Axenfeld-Rieger syndrome, and coloboma. So these are all kind of things that kind of look at eye conditions that affect the look of the iris and have other things going on. Coloboma, you might have remembered that. Madeleine McCann was always said to have that keyhole shape to her iris, or to her pupil rather, and that's coloboma. So that can affect just the iris, and it's basically kind of a slit, a hole in the eye. It can affect just the iris, or it can affect the kind of all the way back into the retina. So that's it. We've checked your knowledge. Hope that helped. Just a quick summary. Aniridia means absence of the iris. It affects many different structures within the eye. Its cause is genetic and is usually caused by the PAX6 gene. It occurs randomly, or it can be inherited from a parent who currently has aniridia. It may lead to other eye conditions and other health conditions. The level of sight and occurrence between aniridics varies considerably, as you'll sort of notice from people here who have it. And every case is very different. There is no cure for aniridia, but there are treatments for some of the associated conditions. That's it from us. If you've got any questions or queries, we'll gladly answer them now. We've got a few minutes. But otherwise, as mentioned, we do have the question and answer session later with our expert panel. If you would like to sort of submit questions to that privately, if you kind of don't want to speak up during the session, please write them down on a bit of paper or ask the guys at the information desk, and we'll give those to the moderator, and she'll read the question out for you on your behalf. If you have any questions after today, you are very welcome to email inquiries at aniridia.org.uk, and that will come through to the team, including Jenny, and we will do our best to find an answer, either from our own knowledge and experience, or we have our very distinguished team of medical panel, and we'll pass out your question on to them as necessary. In addition to that, and particularly if your question is more kind of social or esoteric, or you kind of want to know what other people find, good idea is to post it on Facebook on the Aniridic family group. Heartily recommended if you're not a user of that. It's an international group, loads of people who have Aniridia and their parents on there. And so if you want to know what kind of swimming goggles would be best for you, I used that when I went to Italy a few weeks ago. Went out and got some mirrored goggles on the suggestion of Aniridic family group. Those kind of things. Post your question on there and you'll get loads of really, really useful responses. Also it's things around child education, things like that. Just one thing I would say about that is be aware that a lot of people who post on there will be from the US, just because there's more of them. So sometimes they may say things that don't quite make sense, and because they're referring to like US school system or US health service. That kind of thing.
And it's open, not a private group.
It's an open group, yes. So anyone can see what you post there. So just kind of be aware of that. That's it. Any questions?
Hello, I just want to take a few minutes from you guys. I'm a member of Aniridia Europe, like Katie, member of the board. And last year, Aniridia Europe developed some really nice brochure about Aniridia. So this brochure has all main information about Aniridia and a lot of questions what I hear today. You can find answers in this brochure. And why I open this subject about brochure? In the presentation, you say, guys, you have to check your eye pressure only 1 or twice a year. So, in this brochure, definitely recommend to check eye pressure every 3 months, because 75% of Aniridic patients could have glaucoma. So, it's really big risk. So, I think, because till now UK has no guidelines for Aniridia, you can just read this brochure. It's like a recommend what you should do, what you should not do if you have child with Aniridia or have Aniridia by yourself. But I think it should be more often, so not only 1 or 2 times a year. It could be 1 time in 3 months. Now, this first point. The second point about keratopathy. If you have a first stage of keratopathy, could be some treatment which being developed by Dr. Barbara Kessman, who's the head of Aniridia Center in Germany. She has her list of medicine which patient could use with his first stage keratopathy to stop keratopathy. And it's really work. 2 years ago, I've been with my daughter in America in the Aniridia AFI conference. So she's been checked by Dr. Freeman, who is a corneal specialist. And he said, yeah, she has a first stage of keratopathy. So the cornea start to destroy from periphery. Then we following with the Dr. Barbara Kessman with this kind of treatment, what she recommends for on the first and maybe earlier second stage. This year, in August, there was another AFI conference, the same doctor checked my Lisa, and he said, oh, what did you do this 2 years? You do something? The cornea look a lot better. So it's not just a stop. So it's become better. So I want what I'm talking about. So he take from me this kind of medicine what I use. I said I'm going to study this. And it's only, I will say for you the names. It's only cornea gel, which is preservative free. I don't know. It's made in Germany. The yellow packet. and Bepanthen Augen, Bepanthen eye cream, but we put in the night time before she sleep. So in 2 years we find it's worked. Maybe it's interesting for you. That's it.
I just wanted to add to that to say we do have copies of the Aniridia Europe leaflet. I've only got 10 copies available, but we do. We can give you a link to view it on the Aniridia Europe website as a PDF. So if you can do that, that would be best. But if anybody does want a paper copy, as I say, I've got 10 of those. So if you've either got accessibility issues with PDFs, or if you wanted to have a look at a copy and see what's in it, we have got one on the information desk for you to have a look at. In terms, I wondered if maybe whether Michael, could you comment on glaucoma? How often people should have their pressures tested?
So I think there are differences in Europe and the UK and the States from the way services are organised. So in Europe, you tend not to go to your GP, you tend to go to a community ophthalmologist, and then if you need surgery, you go to a hospital department, and most of the ophthalmologists in Europe don't actually do surgery. So that, in a way, there is better access for things like getting your pressure measured in Europe than there is in the UK, I guess. And so a lot of people who don't have a radiographer who are getting their pressure checked, most of that is done through opticians. But opticians are only, in this country, are only funded by the health service to do sight tests once a year. And so you would have to pay extra to go to them to have your pressure tested more often than that, in all likelihood. I think if we saw a child with aniridia, we'd probably see them at diagnosis, probably see them at 3 months, and then it would depend a bit how frequently we'd see them in terms of their pressure, on the basis of whether they looked like they were high risk for glaucoma, whether their pressure was a bit high. So I think on average, we'd probably see people once every 6 months to check the pressure, but we might see them more frequently than that if we felt it was high risk.
Thank you. Thank you very much, everyone. It's very, very valuable.